All right. Welcome. Greetings. I did come the words all the way from California. I do have a really big meeting today because without telling us, JetBlue decided that my flight is going to be 2 hours late. And they apologized, but never said why. So a bit of a rush act to get here, but I'm happy we made it. Happy to be in front of you. I was here at this Innovators Forum in Lancaster. Larry, what year was that? Like 4 or 5 years ago?
2019.
Wow. Pre-COVID.
Time flies.
Yeah. So it's great to be back, and there's at least one person in the room who was there at that time, and you get to see him. That was the beginning of the story I'm about to tell you, with our efforts to do social impact investing in healthcare. And now we're 5 years in, and the story is a success, I'm happy to say, and we're making a difference in the lives of hundreds of thousands of patients with facilities across the country. So, our company is Turner Impact Capital. We are a for-profit solution to the difficulty in attracting capital into areas in America, communities in America that are underserved. They can't get capital. They can't build infrastructure, and because they can't build the infrastructure, they can't have primary care services. So our mission of the company in which my fund, my Social Impact Healthcare Investment Fund exists, the mission is to bring infrastructure, the capital needed for it, and the expertise to build it to your programs that exist and provide community-facing primary care to address one of the three gigantic challenges in America, the three social challenges: education, affordable housing, healthcare. We are the healthcare piece. I'm going to talk about the education and the housing also. Let's see if this moves. We can't get it to move. Let's see, Larry, what happened here.
I don't think it's on presentation mode.
Yeah, I don't either. But where is the, no, let you do it. Where we have an expert? It's a PDF. I think that's what it's getting. Should be able to expand it. Oh, here it is. Down arrow on the right. See it? Right there. Try that. Oh, we may have to do this the old-fashioned way and wing it. So, what is social impact investing? It is the belief that a market force is the only way to drive scaling on a large scale what you want to build and make it be sustainable. Government grants are great, but they run out. Philanthropy is great, but it's not there when you need it the most. Market forces can be used, this was our thesis, can be used to achieve getting the capital needed to address those social challenges in those three areas. Our education fund started 10 years ago. It's the same model as our healthcare fund, but it deals with building schools in underserved communities. 10 years in, we have 120 schools that we have built. They are serving about 56,000 students every year, and it's K through 12. And if we were a school district, we'd be, those schools we built would be the 26th largest school district in the country, making a huge difference in the lives of the students. Graduation rates, going on to college, finishing college, going back into their communities to do their careers, many of them going into education themselves. But the point is that it was investors who saw an opportunity to make a difference, do well, and do good at the same time. That's the theme with their money. They want a return. They don't want to give away the money, the investors, but they want a return, but they'll accept a return that's reasonable compared to maybe a higher risk, higher return luxury condominiums in Miami Beach, for instance. They will invest in us, let us use that money to provide the capital to be able to build that infrastructure in communities that we target across all three funds. Urban dense, racially and ethnically diverse, underserved in the area that we're talking about, the field we're talking about, education, metrics that the government says that's an underserved community with either a failing district school or no district school. So these are charter public schools that we build, okay? The state pays per student, it's almost like a capitation per student per month, essentially, and then a private charter operator operates it. In our case, we pick the best operators. Can't do it? Okay. We pick the best operators in the land who do charter school education, and we partner with them in a model I'm going to describe to you in healthcare, same model. Housing, 5 years ago, we now have, it started 5 years ago, we have 14,000 housing units around the country, affordable rental multifamily housing. Imagine a 2- and 3-story garden apartment complex, and it's on a campus, and it's in a city, the same types of communities we target, generally 350 to 500 units per campus. And what we do is put an enrichment center right in the middle of that campus when we begin to own and operate the property. What do we do in the enrichment center? We offer programming to everybody who lives there for free, things like health literacy classes for kids and adults, after-school tutoring for the kids who need it, health fairs, screening clinic, screening for diabetes, hypertension, vaccine clinics, all of it free. All the curriculum and the classes being offered are done with volunteers who live in that housing community, and in exchange for them doing that, they get free or reduced rent. The model works to do one critically important thing. It extends the average length of tenancy of the families who live there. In America, little known factoid, 50% of multifamily rental housing units in America are vacant every year because of turnover. They don't stay vacant, but they turn over, right? The average family moves every 2 years, so every year half of them are out. That cost of turnover, fixing the apartment, re-renting it, et cetera, 1 or 2 months, nobody in it, that's the largest single cost for the landlord. So we're the landlord in this model, and if we could increase that length of tenancy, the largest expense item on the balance sheet goes down. You don't have to raise rent. So our goal is that nobody pays more than 30% of the family take-home pay on their housing. That's getting really hard to meet, but we still are able to do it in these units. Those enrichment centers make a world of difference in the landlord-tenant relationship. So we bring costs down, we're able to do this model. Who lives there? The people who live in these complexes, blue-collar America, teachers, city workers, county workers, state workers, healthcare workers, people who teach in the schools we build, who come home to live in the facility we own and operate, and do the things that the kids, oh, great, thank you. Do the things that the kids need, like after-school tutoring and so forth. Law enforcement lives there. They live on campus, they offer community watch, organizational programming. We thought that the healthcare people who live there would be the staff supporting the people in the white coats in the healthcare facilities we build nearby. And yes, they do live there. But who also lives there, to our surprise, were the doctors, the young doctors, the residents, the medical students who live nearby. The doctors had loans to pay back and needed housing that was affordable. And they get involved in organizing the curriculum for the programs.
say yes.
Yes, right? Okay. So that's a little bit about that fund. The third fund that we operate is our healthcare fund. And that got started in earnest about 5 years ago with a money raise, but we started building things about 4 years ago. And we have 35 facilities that we have completed that are open. We have another bunch in construction and another bunch in the pipeline behind it. And what you see is the three fund storylines on the bottom. The education fund is a partnership between us and Andre Agassi. I don't know how many of you remember Andre, the tennis star, tennis pro. He dedicated his life to education for underserved students when he finished with tennis. And he met the founder of our company. When he was done raising a couple $100 million, Andre, to build his first school in Las Vegas. It took him 5 years to raise that. Big success. The school is still running. Huge success in statistics around key performance indicators on graduation rates and the students' lives, changing their lives. But my boss, Bobby Turner Impact Capital, Bobby went to Andre and said, you got to do this, and you got to do it a different way. You got to have a market-driven model with investors to raise enough capital so you can build 100 schools, not one school, and make a difference. And 10 years later, 120 schools across the country. So that's that fund. Our multifamily impact fund is the one in the middle, the blue box. You can see the wording there and what it's up to. Big success in keeping affordable housing available. You know the biggest challenge we have in that fund? It's not raising money. We have investors who are eager to contribute money and invest in it. The biggest challenge is finding properties. What's happening across the country in communities that we are targeting, underserved communities, communities where people can't afford to rent anymore, are disappearing because developers are buying these properties, they scrape them, and then they build luxury housing that's unaffordable. That's our biggest challenge. And we're able to meet it so far and continue to meet it with a lot of hard work and a lot of people in the team. That number's outdated, 10,900 units. We're up to, I think, between 12 and 14,000. It goes up and down as we buy and sell properties and are able to expand the fund. So the third fund, healthcare, is what we're going to focus on. Our healthcare fund, as I said, 5 years ago, raising money, 4 years ago, built the, started building and constructing. So how do I move forward here? Let's see. There we go. So here's the facilities fund. So what we do is build to suit solutions for healthcare providers who we partner with. And those solutions are all underserved communities, urban dense, racially and ethnically diverse, medically underserved area, MUA designation, or health provider shortage area, HPSA designation. The partners we do this with are primary care groups, local, regional, and national networks. We love to work with community health centers and FQHCs. We have a number of facilities successfully built with them. How many of you are familiar with the PACE program? Program of All-Inclusive Care for the Elderly. That is the best kept secret in America. It's amazing that we don't have 10x the number of PACE centers in America. Right now, as we stand here, there's only a couple hundred of them. Maybe we're approaching 275, I think. PACE centers across about 140 PACE operator organizations. So we partner with the PACE operator to build the facility infrastructure they need to open a PACE center. And we provide the capital and the expertise to develop it in a very unique model, which I'll explain financially in a minute. But here are some of the facility types that we do. All of them core primary care. So we're about primary care in underserved communities, community-facing. We don't build hospitals. We do have some transitional housing, medical respite facilities where people stay overnight, but that's the closest we get to kind of an inpatient setting. There's our footprint nationally, and you see the billions of dollars that we've raised to do all this, and it goes coast to coast to coast. I have to include the Texas coast or the yellow line. So coast to coast to coast. In all the regions, we have a presence. We're headquartered in Southern California, but we have people feet on the street in every one of those areas. We have construction managers, real estate network people. It is a thing that I never thought I'd be doing as a family doc. What happened in my life, this all happened when a friend of a friend introduced me to the leaders at Turner, and they had this wild idea for their third fund, the healthcare fund, to address the social issues that really matter as much as genetics and everything else going on in medicine, the social impact issues, and change people's lives. And I said, my first reaction when they said to me, "We want you to run the fund," I said, "Are you crazy?" And that was probably because of my family medicine thinking. You know, it's like, what is a family doctor doing this? You crazy? I don't know anything about real estate and finance and Wall Street and lawyers and, you know, all the drama of developing properties. And then they said, "Don't worry, we don't need you for that. We will surround you with very smart people, most of them millennial age, who know how to use a spreadsheet while they're sleeping, whose hands I can't follow with my eyes as they move across keyboards so fast." They're just amazing, amazing team of people. They needed me because they knew they were committed to this being all about value-based primary care in underserved communities, and that was my life. That's what I did in my medical group for many, many years. Here we are 5 years after that conversation happened, and we are at 35 facilities and growing. So, what's the model? Very simple. Our clinical partners tell us where they want to be, what they want to build. We find the property for them. They tell us out of 10 or so properties that we present in the zip codes they say they want to be in. We show them all 10. They pick the one they want the most. We execute a purchase agreement with whoever owns the land at that point, and then we are off and running to build what we need to build for our clinical partners. In the transaction, we provide 100% of the capital needed to open the doors. In exchange for providing that, we sign a long-term lease with the clinical partner. That long-term lease is generally 15 to 20 years with 2 5-year options. And the rental rate in that lease, where we're the landlord and the clinical organization is our tenant, that rental rate is based on a credit risk underwriting and a clinical quality of care underwriting. We do diligence in both those tracks so that we're convinced we're getting the best of the best in terms of the clinical care provided. And we can go into as much as you want what that clinical diligence is all about, but it's essentially quadruple aim. And questions around how are you organized to deliver great patient outcomes, great patient experience, control population cost, and recruitment, retention, and issues around the satisfaction experience of the care team, doctors and the team that support it. So really a quadruple aim checklist, if you will. We don't just do build-to-suit facilities, we also do sale-leaseback transactions. So what does that mean? A lot of organizations, especially federally qualified community health centers, who have been around a long time, own property. That property is aging, they're growing out of it, right? They need cash to do operations, but they have assets on the books of real estate. So what we can do with our capital that we have is buy that real estate from them and then lease it back to them in the model where the lease rate is completely based on that diligence and the total budget of the project. It's an open book, completely transparent transaction. Whether it's a build-to-suit or a sale leaseback, doesn't matter. It's a completely line-by-line item
transparent, open book. What's the total cost of doing a project? That gets turned into the rent, and the rental rate is simply the result of the credit risk underwriting of the clinical and financial diligence. So example, make it real simple. Let's say we do a project with an organization in Connecticut. They have a large primary care network and they want to build a community health center. So we find the land, they pick the one they like the most out of 10 options for properties that are available. We execute the purchase of the land. We add to that the hard and soft costs of construction. That means the cost of all the materials, the cost of the labor, the cost of the land use attorney, the cost of the permits, and long list of items, but every item is very visible to us and to our clinical partner. Nothing is secret, nothing is hidden. We total it up, total project cost, let's say it's $10 million, just for argument's sake. And we've arrived at a rental rate that generally usually falls between 8 and 10%. Multiply the two, $800,000 is the rent per year. Divide by 12, monthly rent. We always give a purchase option to our clinical partners if they want to own it back, right? They certainly get it back in the sale leaseback. We give it back to them for the same amount of money, right? They pay us back the same amount of money that we paid when we did the original sale and leaseback. So if you have an organization and you have a building that's assessed at that $10 million and you want to get cash for operations, free up some money, make it liquid, you take that asset that you own, we buy it for $10 million, we give you the $10 million, you have the cash, and then you pay us in the lease based on a rate that is, again, what's that credit risk underwriting? And then at 3, 4, 5, how many years out, you might be interested in buying it back, it's the same $10 million. So essentially, we're providing a loan that can go up to 100% of the value of the property. Now, on the build-to-suit facilities, which is generally about 2/3 of all the work we do, 1/3 being the sale leasebacks. On the build-to-suit, we always give a purchase option, and the terms are set in the lease originally. It's not fair market value to purchase back, if you want to, that facility. Same thing. It's the total budget cost that we all knew from the beginning, and you can buy it back at that. Not fair market. So a great deal, part of our mission is to make sure that the clinical organization is sustainable in the community and long-term and serving the needs of the patients there, making an impact. That's the model. It's that simple. Very simple, very straightforward. Here's the build-to-suit kind of blown up on what happens. We have internally, we have real estate people, we have construction people, design people. All of that's included in that original purchase, budget cost. And there's nothing hidden, there's nothing tough to understand. This is what we kind of explained in the last few minutes. What I want to get to, before Larry hooks me and takes me off because we're running out of time, what I want to get to is this. We track and report to our investors. We have to. We're obligated by our operating agreements. Performance indicators. Are we making an impact? Is their money, is their investment impacting the people and the community in a positive way? So we have in the lease reporting requirements that they have to give us, which we then give the investors. What you're seeing here is the latest year's aggregate KPIs, and we'll look at those numbers. These are across the 35 facilities. These are normalized numbers, so they're really comparing apples to apples. And our panel size per physician is 5 times better. That means the average primary care panel in the facilities across our portfolio is generally around 400 to 600 patients, not 2,000 to 3,000. How do they pay for that? Because of better primary care access, more face time with their primary care teams, proactivity, not reactivity in doing care, preventative care, chronic disease management. We get less hospital bed days, we get less readmission rates, and across all of what we do in these 35 facilities, how many of you are familiar with the Net Promoter Score as a metric of patient experience? It's new to healthcare. In other industries, it's been around a long time. What it is a distillation of a whole bunch of things into one number. That one number is essentially how happy is the customer, in our case the patient, with the care they're getting and the experience of getting that care. For healthcare in America, the net number, NPS number, is generally running around 28. It's a scale of -100 to +100, right? So 28 ain't so bad. I mean, Congress is, I think, around -10. Lawyers are around 0. This is true. I'm not making it up. I think these are the latest numbers I remember. So healthcare in general, 28. We are 3 times better than that. So what's 3 times 28? We're in the 90s across our portfolio. Extraordinary patient experience scores. Extraordinary patient outcomes. Making an impact in people's lives. Longevity, morbidity, mortality, perinatal mortality. So, just in case you're wondering, we don't come in and just tear apart the neighborhood. We are very environmentally committed and favorable. We have an independent third party assess every property we get involved with our clinical partners. We do a pre and post assessment. What was going on the property before we got there? If there's a building on it already, how did we improve the building? And if there's no building on it, we use standards, averages for that community area. We have, as you see here, of the 35 properties in first portfolio fund, we're at about 2/3 adaptive reuse of a building that was already there, and 1/3 ground up. But look at the scores. Whether you're talking about water usage, electricity usage, building materials, we have a net 54% increase in the rating of the environmental compatibility of the project that we did. The United Nations has 17 SDGs, Sustainable Development Goals. These are selected, 8 of them, all of which we're targeting for what we do in terms of improving the communities that they're in, improving the lives of the people in the communities. Here's a next slide. Here's a sample of the project. Our favorite is to do a community health center and a pay center in the same building. Those are the 2 on the upper row there on the left. One's in Southern California, near San Diego. The other one's in the Inland Empire in California. And they were not both. The one in the middle upper here was an adaptive reuse of an empty office building, and the one on the left was a ground-up construction in what had formerly been a closed-down car dealership. Both of them now taking care of thousands of patients, doing PACE on the first floor, community health center on the second floor, and full to the brim with patients having their lives changed. The third one in the upper row on the right here is a PACE operator that's for-profit, relatively new. We've done a number of their centers that they've opened. That one happens to be in Fresno, California, in an underserved area. And it is full, and we're looking for property for them for a second one. Down below, you see some Medicare Advantage centers. Big presence here at the meeting. One of your key sponsors is ChenMed. We built 6 centers for them in Florida. That's one of them. Most of them were adaptive reuse of closed-down drugstores like Walgreens, CVS, and so forth. And my favorite one over here, I'll finish with this, is called New Freedom in Phoenix, Arizona. It is, if you look at the picture, I think most of us would say, whoa, that looks like a hotel. It was. It was a closed-down hotel. I think it was Holiday Inn. What's the high-end Holiday Inn? Crown Plaza. It was a Crown Plaza, which closed because of COVID. We bought the property, and with an organization that was doing healthcare, behavioral health services for incarcerated individuals, they created a program for when the people who came out of incarceration to put in one spot, that campus we built for them out of that hotel, services, intensive behavioral health services, primary care services, vocational training, permanent housing placement after they stayed in this setting for about 60 days average. You can go 30, 60, 90, depending on how they did. In one location, instead of having to go all over the city for all services also. It started 3 years ago. And the goal was to get everybody a job, get them permanent housing, right? Train them on what job they were going to get, train, do vocational training. And their target metric was reduce recidivism. They're 3 years in, they've reduced recidivism 92%. And every one of their graduates, 100% of them graduate with a job and a permanent housing placement. 92% reduction. We are now building already in construction as we speak, their second job. All of that is paid for by Medicaid, by the way. It's a Medicaid waiver that the state came up with and allowed to use the Medicaid money to do that and make a change.
Give my hands up. You say there's time for just one question. Maybe from our reactors?
No question, just admiration. I have run 3.5 build-outs of practices in my life, and I wish the heck you did.
Thank you. I tell you, my mentor when I was in residency, when he retired, somebody said to him as retirement, why did you start a family medicine training program when you were 73 years old? And he laughed and he said, it took him 73 years to realize that as a doc in a white coat seeing patients every day, maybe I help 30, 40 people. You know, live visits, phone, whatever it is. But if you can train people and make it possible for a bunch of other doctors to see the patients, you multiply your impact greatly. So when this opportunity came to me and they said, we want you to run this fund, I'm not thinking, well, I'm going to miss the patients. Yes, I miss the patients. But first of all, we have 35 people working in my headquarters building, and somebody's sick every day. Every single day. But second and most important, I'm thinking, I go to sleep every night thinking, wow, we have 35 facilities. We're serving hundreds of thousands of patients that would not have a place to go and get primary care access. And they're getting great care and making a difference in lives.
So Len, as a final point, why don't you tell them how much money you have to spend?
So our first fund to build the 35 facilities came into a total of $300 million. Our second fund, which we're now in the middle of, building a second set, we're going to get a few more investments. It's going to be $700 million. So the capital is there. We don't have to go anywhere outside of primary care to get approval. There's 5 votes in our investment committee to approve spending that money on one of the 5 votes. It's 100% primary care voices. Maybe not family medicine docs, but people who completely and 100% understand that is the foundation of solving so many of the problems in our healthcare system.
So I mentioned to you before, for those who were here, the conscious capitalism. This is conscious capitalism in action. This is, we're going to use market forces, but we're going to invest it in the right way and partner with, not do things to. So I just, Len, just want to thank you for what you're doing, and thank you for coming here.
Appreciate it. Thank you for